Hello, and welcome to the fourth podcast in the series by Dr. Ed Kim on managing postoperative patients. In this podcast, we're going to go over the initial.
Who are you?
Oh, yeah. My name is Mark Stoddard. I'm an intern on service with Dr. Kim.
Great. So, in this podcast, we're going to go over the initial steps in evaluating a patient when you're called for an apparently acute problem. And the goal is that at the end of our conversation, we want you to have a relatively simple algorithm that you can continually use and practice and get better at over a period of time on how to evaluate a patient.
Yeah. So as the intern on the service, you're kind of the eyes and ears of the service. So you will be the first line, maybe 90% of the time, getting those first calls. And definitely in the beginning, this is going to be stressful. Over time, you'll get more accustomed to it. But the most important thing is to have sort of a thought process that you can use each time when you go see the patient. So first thing you want to do is figure out why you were called to see the patient. And the second thing you want to do is figure out whether you need to go see them right now or if this is something you can do later.
So now it is a difficult decision to make, right? Because I guess the first decision is whether you need to see them at all. But shouldn't you go see everyone just to be sure right away?
Maybe like in the ideal world you would see everybody every time, but in the practical world the fact of the matter is that you may have 10 to 30 patients and you have an infinite number of responsibilities, and if you are constantly responding to each page, each concern, you'll never get things done. So you have to triage and be efficient and prioritize what are the things that you need to do. So in the beginning, you might have to see a few more patients than you might towards the end of your intern career, but you want to get good at triaging over the phone, essentially.
Okay. So how do you decide to see a person, and how do you decide to see a patient in person, and how do you decide who needs to be seen right away? Are there any simple rules or guidelines that you can kind of impart your knowledge now that you're a seasoned intern?
Yeah. An oldish intern. So usually when a person first calls you, they're going to have a specific complaint or concern that the nurse is going to have. So for example, the patient may have spiked a fever, or now they are requiring more oxygen than before. And each of these things can have like a pretty broad differential. Some of those things can be totally benign. Maybe they're just not breathing particularly deeply, or they can be life-threatening. Maybe they have a new pneumonia, or maybe they have a pneumothorax. So you really need to get some information together in order to decide whether you're going to go see the patient stat or not. So the couple pieces of things you can work with: number one, you have your sign out, both the document and the verbal sign out that you got hopefully prior to coming on call. And the second thing you have is the nurse. The nurses obviously may have years of practicing medicine ahead of you, and she will be able to provide you, or he will be able to provide you with excellent information over the phone. So you want to get the vitals, you want to get urine outputs if possible, you want to get I's and O's. If you don't know what the labs are, if they're not on your sheet, then you may want to get a hold of those if the nurse has those.
Okay, so I guess to summarize, you're saying that when you talk to the patient or when you get the phone call, you should get additional information rather than just whatever the one-liner. So you get that information both from the nurse, and that information you're saying are vitals, urine output, some of the basic numbers, and the other is on your list. You were saying you want to get an idea of what the patient had, whether they're high risk or not, what their past medical history was.
Definitely true. I mean, there's different levels of problems that you can have. Like some patients are going to be high risk and some are going to be low. However, there are some general problems that you're pretty much always going to want to see. So the short list of that would be shortness of breath, new hypoxia, that is like low O2 sats or requiring more oxygen, chest pain, hypotension, tachycardia, acute changes in mental status, sudden unexplainable bleeding or changes. I would also add pressors on there, sudden increases in pressor requirements.
For patients in the ICU.
Yeah.
Yeah, so it's kind of like ABC, D.
Yeah, pretty much.
Yeah. Okay.
Yeah.
So if we were to summarize these initial steps again, so number one, decide whether you need to see the patient in person, and decide whether you need to see them right away. Is that right? Number two, you decide and you make this decision based on the information that you get over the phone, which you can elicit from the nurse, such as vital signs, urine output labs, and then on the list as well. And then repeating again what the probability of the complications would be in your patient. Is your patient high risk based on the operation they had and how healthy they were before? And then lastly, we just talked about a list of must-see symptoms and signs, which you can kind of think of it as ABC.
Right.
Okay, then what next?
Yeah, so you've decided the patient is like a high-risk patient, or they've got one of these ABC problems, and you're going to go see them. So now you go see them, and you want to get an abbreviated history and a physical exam and a review of some of the pertinent data.
Now, can you tell me a little bit about how you go about doing this? And the reason why I want to ask you this is that now our audience is going to be either freshly minted doctors or still medical students, maybe sub-Is or even third years, the precocious ones. And their sense of going and seeing a patient is a little bit different from what you're thinking. Is that right?
Yeah, that's correct. So if you're on a medicine rotation or if you're in the ED, it's possible you might have a very broad differential, or possibly when you're doing that H&P for the first time, you're going to have a broad differential. But in the post-operative patient, really what you're thinking about are what are the most critical problems that can immediately kill this patient. So things that are acute bleeding, massive PEs, losing their airway, anastomotic leaks, massive intra-abdominal sepsis. These are like must deal with problems right now.
Can't miss, worst feared,
exactly,
most devastating complications.
And then in addition to that, you also want to think about what is the most likely thing that's happening with this patient, because not every one of these patients is going to have the massive PE. A lot of them may just have some pain or something along those lines.
What's your percentage in your experience, at least your perceived percentage of false alarms versus the true emergencies?
I would say it does depend a little bit on service. It depends on the weight of the ICU versus floor, but I would say that 95% of the time to 90% of the time, it's not going to be the critical issue.
Right,
so you're probably going to see at least 5 patients for every 1 patient that actually.
But it sounds like you still want to be that cheerful pessimist, right? Assume the worst, rule it out, and then also think about, so you go in there thinking about what the worst case scenario is and what the most likely benign scenario is.
Yeah, it's basically your job. I mean, particularly as a surgeon as opposed to a primary care doctor, it's your job to be that cheerful pessimist, certainly.
Got it.
So basically we should go over some of the worst case possibilities and what we're going to do as we go in the room. So I think the first thing you want to do is you do want to do the eyeball test, and you also want to do, I would say, the ABCDs of the ATLS primary survey.
Yeah, I mean, and I do want to add the value of the eyeball test. And Mark, I don't know if you knew this, but we talked about it in a prior podcast. But use your instincts to know whether somebody looks like they're in trouble, and then try to determine what the objective facts are. But go ahead.
Yeah, I would second that. I would say a lot of times when I was in medical school, people would talk about the eyeball test like it was some sort of magical thing where they would be like, oh, you'll get better clinical intuition. But as I've seen some stuff, I'm starting to believe that really, if the patient looks really truly awful, and most people know what that is, then something's wrong probably with the patient.
Yeah, and you're just basically looking for objective way to express that or communicate that. Is that right?
Yeah, that's right.
Okay, so can you tell me a little bit? We were talking a little earlier. You were saying your approach is like this ATLS approach. Can you, when you go in and see a patient?
Yeah. So number one, airway. You look at the patient. Is the airway intact? Do they have? I mean, that's as simple as that. Can they speak to you? Number 2, breathing. Are they grossly tachypnic? Are they on 20 liters or whatever? Cardiovascular is the next. Do they have a pulse? Next is disability. I would put with that like gross changes in mental status. Obviously not able to move one arm, aren't able to respond to you or wake up. So that's the basic ABCD that you want to do.
Okay, so then how do you synthesize all this information? It seems like it's a lot to go in there and then figure out what's actually going on. Is it the worst case scenario? Is it the most likely?
Yeah, so I mean, if it's one of those initial problems, then you're gonna, those ABCD problems, you go through the algorithm, the ACLS algorithm, the ATLS algorithm, like you would for anybody else. Let's say you get past that, now you're on to the person that's hypotensive and has but you're not 100% sure why they are. So then you're going to want to get to those lab values and those initial important tests that you're going to do, which are likely going to include something along the lines of getting chest x-rays, getting simple basic labs, which are CBC, BMP, including the divalence, calcium mag phos, probably an EKG, probably that chest x-ray.
Okay. So can we summarize? I think we're at the end of our podcast now. Number one.
Number one, you want to decide whether this is a person you need to see or not see, and that's based largely on information from the nurse and the vital signs,
as well as your prior
sign out
and whether they're high risk or what their anticipated trajectory is. Okay. Number two, as you go and see the patient,
you want to decide whether this is a truly awful scenario or not, basically with the eyeball test or by considering, this person just immediately came out of the OR with, 4 liters of blood loss. That's
and
something
then
you take seriously.
Lastly is
you want to evaluate the patient, so you want to do that ATLS evaluation. You might want to do a simple history and a simple physical. Then you want to start evaluating your data. Consider try to rule out the most critical problems, and then you think about what could be the most common explanation for the scenario.
Excellent. And then can you go over a little bit of like what the privileges of an intern are in terms of like having the authority to order stuff?
Yeah, I think generally the privileges of the intern, so to speak, is more or less what I said. Is the chest X-ray, most X-rays, in fact, you can do. The basic labs you can do. Sometimes you can give some volume, up to about 500 cc's, I think is generally acceptable. Beyond that, once you're starting to think about blood, once you're starting to think about any vasoactive agents, if you're thinking about any antibiotics, it's time to
bump it up.
Time to bump it up.
Get the approval. I mean, you want to talk to your senior already,
yeah,
but you shouldn't order. I mean, I think you can order these basic studies before you talk to the seniors potentially. But I think what you've discussed, along with I think CT scans, right?
Definitely,
are something that
Echoes,
you're going to need approval or subspecialty consult. Great. Thank you very much, Mark. And I think in our classroom discussion, we're going to go over practicing these types of step-by-step approaches to specific problems, and the rest of the podcast series is going to go over specific symptoms and signs that you're going to be called about. So thank you for listening.
Thank you so much,
Mark.
Dr. Kim.